The patient journey begins with pre-injury education and administration of a baseline cognitive test. When an injury occurs, the coach's clipboard tool is available for sideline use. If there are signs or symptoms of a concussion, immediately remove the athlete from play. If there are any red flags or concerning factors present, the athlete should be taken to the nearest emergency department. The patient should immediately contact their family physician, nurse practitioner, and the youth sports concussion program. After injury tests will be scheduled and take place at 150 King Street, Peterborough. The after injury test is supplied to the doctor and/or nurse practitioner, and the patient will receive a clinical evaluation with that doctor and/or nurse practitioner. If there are any concerns, advanced imaging or specialist referral may be required. If the after-injury test is not at baseline or the clinical evaluation is not considered normal, further physical and/or cognitive rest and possibly rehabilitation may be recommended, followed by a repeat assessment. Ideally, visits should be weekly early on. When the patient reports being asymptomatic at rest, after injury testing has returned to baseline, and the clinical evaluation is considered normal, an individual may begin a return-to-play protocol. If there is a recurrence of symptoms, the individual may be required to reinitiate the return-to-play protocol, or they may require further testing, assessment, and in some cases rehabilitation may be an option. Once the athlete is successful through the 6 stages without recurrence of symptoms, they may return to play. In the setting of a concussive event, we don't truly always know what is the pathophysiology behind the injury. There are studies ongoing and there are thoughts that exist as to what may have occurred. Currently, we believe this injury may represent a neurometabolic injury which is occurring at a cellular level. The key to understand is concussions do not represent structural brain injuries. From a neurometabolic perspective, we believe that there may be mass depolarization of neurons which lead to shifts in ionic balance. These can cause a hyperacute metabolic state as the brain is essentially working overtime trying to reset the homeostasis or ionic balance within the brain. We feel that the hyperacute phase after an injury in which we see this heightened metabolic state may represent a period of neurologic vulnerability. In other words, if the brain, because it is working overtime trying to reset ionic balance, is presented with increased cognitive tasks and/or physical tasks, it could theoretically be a setup for neurologic impairment or not allowing us to optimize recovery moving forward or slowing recovery. On the flip side of that, as time passes, and we truly don't know how long that may be, potentially 7 to 10 days, it depends on the individual, there may be a phase of metabolic depression or in which we see this lag in the metabolic activity of the brain. We feel then that some of the symptoms thereafter, the acute phase, may correlate with that. The picture of an individual who is feeling maybe somewhat drowsy or is feeling that they are dragging or having difficulty concentrating or what have you. Studies have been complete in moderate and severe injuries. We don't have the same degree of information in mild traumatic brain injury or concussion, but we suspect that's maybe what we might be seeing.
Well, cognitive rest is what we now recommend for people who have been concussed. In the old days, we would just say physical rest. But in the last 10 years or so, we have also been recommending cognitive rest. So that means if a kid is concussed, they shouldn't go home and expect to get all their homework done that night. And they shouldn't be expected to get the assignment in on time, because we now know that exercising the brain by thinking too much, by too much mental activity, actually slows down recovery. So if you want to recover more quickly, you rest your brain. Rest it from both physical exertion and cognitive exertion. And that may mean different things for different people. But it means that school teachers, for example, have to be aware of this, so that when a kid returns to school, they can't be expected to just pick up where they left off. They may only be able to return, for example, an hour a day initially, and gradually build up.
Well, it's critical to see kids within 48 to 72 hours of the onset of a suspected or a confirmed concussion, just to get them into the system, to get some baseline testing redone to see where they are, to get some perspective as well about other conditions that may be at play, and to ensure that the best care advice is given from as early in the process as possible, so that that care pathway can take place efficiently and effectively and with the best evidence behind it.
The truth is, you can't predict a course by laying eyes on someone. We know that we have to take each case on an individual basis, and we have to be patient, and we have to continue to follow progress. It's just not enough anymore to give predictions. Predictions, you know, what's the value? There's no crystal ball with this, and you really just can't make guesses, because that's what it becomes, is a guessing game. We have to ensure that we're doing the right things, and we do so by following along with the patient, being in close contact with them or any other allied health that are helping out, and making sure that we're trending in the right direction. I think it's an absolute, utter mistake to tell someone you're okay in any given time frame and go back. And even if you extend that to a month, I still think it's a mistake at that point. It's just not the right answer.
Concussion is an illness that we do expect a full recovery in the vast majority. By 10 days or so out, about 40% of kids will recover from a concussion completely, and that would include the return to play protocol after going through that process. There's a certain another 40 to 50%, about 85% total, will recover by the 3-week point, and a few 15% we know take a little bit longer and a little bit more complex. Those are the folks that we don't know how to identify early on in the process, but those are the folks that we really want to pay attention to, because we know those kids are at increased risk of further injury, and we don't want further insults occurring, i.e. the second or third impact syndromes occurring during those recovery phases.
As much as we are trying to be responsible and keep them away from harm or contact until we believe they're recovered, we also don't want to put them on the shelf for a longer period of time, because that's not fair to the child, not fair to the team and or the school, administrators, their teachers, because really we're not just talking about their life in sport and return to that, but it's also return to academic coursework, return to being out in the community, being with their friends, and doing all the things kids should be doing. So I think at a week at a time early on is a good rule of thumb, again, unless the clinical exchange would make you feel otherwise. And typically, again, until that 3-week period, I'm just following along to be sure we're heading in the right direction. If someone has been symptomatic for a longer period, or an injury occurred months or even years ago and they were in my clinic, of course, I wouldn't be following them weekly. I would certainly decide what is reasonable in that setting. Yeah, there are modifying factors that have been identified. I think that, we have to keep in mind again, it's very difficult and really impossible to predict how quickly or how long it will take someone to recover from an injury. Again, we suspect the vast majority of people do well in a discrete period of time. However, when things maybe don't go well, or we have someone who has a protracted course or longer than might be expected, are there certain things that potentially could have predicted that early on? We believe that is the case. Examples would include the threshold concept, and what I mean by that, if we're seeing increasing injuries or repeated injuries occurring with less force required to produce symptoms, that may be a modifying factor. Recency of injuries, in other words, if someone's had repeat concussions recently, and again, we don't truly know how long a period we're dealing with, but that may be a modifying factor. Then we get into non-injury type factors and the person, things being history of migraine and or headache, history of ADHD, depression, anxiety, panic disorder or panic attacks, learning disabilities, etc. Compromised psychosocial factors, and or impaired coping strategies can also contribute. I think a history of psychoactive medications also can be an issue. There is some information out there that suggests the report of dizziness at the time of the injury could be a modifying factor. Beyond that, we also think of family history as well. A family history of migraine headache has also been shown to be a modifying factor. Beyond that, I think in regards to our program, anytime we see someone who's under 18 years old, we have to be very patient and cautious in that setting as well.
There's been quite a lot of work and resources put into tools to aid the clinical assessment. And many of these tools, again, incorporate the best knowledge base we have available for concussion treatment protocols and processes. And these tools, if used correctly, will enable a very smooth and consistent transition from each point of care to the next. And if these tools are used as we envision, these tools can be used to generate many of the forms in a very timely, efficient, effective and consistent manner, such that everybody can be on the same page and we can all be sure that the best care path is being taken, again, based upon the best evidence we have available to us.
I think it may be appropriate to consider referral to a specialist after a sport-related concussion if an individual has not taken on the predicted course. If we see someone who's still symptomatic after that 3 to 4 week mark, that may be a time to make specialist referral. If there are other concerning factors during any time within the course, that may also be an appropriate time to make referral. Let's discuss a standardized return to play protocol. There are 6 stages that ideally an individual pass through prior to be considered for return to play. Stage 1 is rest. There is recommended to be no structured physical or cognitive activity. Stage 2 consists of light aerobic activity. Stage 3, moderate aerobic activity and non-contact training drills at half speed. Stage 4, non-contact training drills at full speed. Stage 5, full contact practice, followed finally by Stage 6, which is a return to play. Typically, we expect at least 24 to 48 hours of asymptomatic period between stages. Theoretically, this would make a return to play protocol at minimum 5 to 7 days and potentially longer. If an individual has been symptomatic for a long period of time or has had a protracted course, then certainly we would recommend a much longer return to play protocol in order to be very responsible. If an individual does not pass through any stage at any time or has difficulty tolerating any stage, then we would recommend they be returned to Stage 1 so they may begin the return to play protocol again. Once they have passed successfully through the stages again, it may be appropriate to clear them for play. I think anyone who's had 2 concussions in one season, I generally have them out for an entire season. I think 3 concussions inside of a year and you're out for a year as far as I'm concerned.
We don't really understand why people get brain degeneration after concussions. It's usually after repeated concussion. So we don't see brain degeneration after a single concussion. At least it hasn't been proven yet. So those who have been proven to have a condition called chronic traumatic encephalopathy, or CTE, those people have all had multiple concussions. And the other interesting feature is that it's usually not right after they've had the multiple concussions, but years later they get this terrible brain degeneration. Even 10 years later, 20 years later, they start to show dementia or movement disorders characteristic of this condition called CTE. And although we now know biochemically that it is what we call a tauopathy, which means that there's an excess deposition of the tau protein in the nerve cells of the brain, we don't really understand why that has happened. And most frustratingly, we have no treatment for it. So it means, it just emphasizes the fact that prevention is the only cure at the present time. Well, there is a list of factors that we consider for non-return to play. And non-return to play can be temporary, or it can be permanent. So if I advise a player to never return to collision sports, so a hockey player, if I say, look, hang up your skates, you're finished, it's usually because I've detected a cognitive deficit. So for example, if there's a significant memory loss that is shown by formal neuropsychological testing, then that would be a factor. If we see any lesions on the MR, that would be another reason for non-return to play. Or if there's a permanent neurological deficit, like any weakness of one arm or leg, permanent imbalance. So those would be significant reasons for saying non-return to play. And the indication for that would be in someone who's had multiple concussions, especially over a short period of time, with decreasing force that produced subsequent concussions and increasing length of recovery. For example, if it takes somebody 10 months to recover from the last concussion, well, to me that would mean don't return to any collision sports, take up golf or swimming.